Hi, thought I'd start this presentation telling you a little bit about myself. My name is Pat Clay. I graduated in 1977 from Research School of Nursing in Kansas City, Missouri with a diploma in nursing. I started my first job as a nurse on the night shift on a 26-bed pediatric unit at St. Joseph Health Center. Eventually worked my way up to being a director over the pediatric adult observation unit and a women's surgical unit. In 2000, after 23 years at that health center, a decision was made to eliminate pediatrics, and I had to make a decision. Am I a pediatrics nurse or an adult nurse? I decided I was a pediatric nurse at heart, so I left the health center and became the manager of Kansas City Hospice Pediatric Team, the Carousel team. After almost 3 years, I went back into acute care as the manager of the new satellite hospital in Overland Park, Kansas, for the Children's Mercy Hospital in Kansas City. After earning my master's degree in 2006 from UMKC, I began my first clinical instructor job at the Children's Mercy Hospital Central location in downtown Kansas City. This was the first hospital-based clinical instructor position for the only pediatric hospital in Kansas City. That same year, I obtained my pediatric nurse certification. I absolutely loved being a clinical instructor. I taught nursing students from BSN programs on almost every single unit in that hospital. When I was not instructing students during their breaks, I worked on the wound ostomy team, eventually earning my wound and ostomy certifications. I became manager of the team as I left clinical instructing after 9 years. I was the only master's person with a wound care certification, so I felt obligated to move into the manager position for that team. I have to say that I enjoyed the challenge of working with the wound ostomy team members to enter the realm of telehealth and establishment of a wound care clinic. I retired in 2020 amidst a global pandemic. My retirement celebration for 43 years of nursing consisted of a small office party where everyone wore masks and goggles. My career spanned from 1977 Star Wars to the 2020 global pandemic. As I worked with nursing students of all kinds, I developed a 3-question method of clinical preparation out of necessity. There was so much to impart to the students with so little clinical time. I wanted the experience to emphasize the work of a nurse. I hope that you can use this method of clinical instructing with your students as they grow into the professional nurses that we so desperately need today. The 3-question method of clinical preparation for nursing students grew out of my 9 years experience as a clinical instructor in the real world of nursing, where many times I saw nurses unprepared to respond to a crisis with a patient. I wanted to send my students to their next rotation or their first nursing job with a sharpened sense of the work of a nurse. I used this method with my students to help them prepare for clinical. I used it in pre-conference, throughout the shift, when we'd have conversations, and then in post-conference. This book was created out of a desire to share this method of clinical preparation with both nursing students and clinical instructors. For instructors, the 3-question method offers a structure for pre-conference and post-conference and everything in between. For students, the method of clinical preparation contributes to critical thinking and reinforces understanding of the work of a nurse. The 3-question method of clinical preparation was designed for use in an acute care setting. Although not officially tested in another venue, this method of clinical preparation is hypothesized to be applicable to other patient care settings. The method reflects the way a nurse thinks. Having the 3 questions ingrained into my mind, I personally used the method as I cared for patients. Inpatient on the float pool or on the wound ostomy team that I managed. I used it on both inpatient and outpatient settings. And being a clinical instructor at heart, I occasionally challenged other team members to think about the worst case scenario with a patient and then to prepare for that, hope for the best, and prepare for the worst. It is important to understand that the 3-question method of clinical preparation does not replace the required paperwork for the individual nursing program. Instead, the 3-question method promotes a way of thinking critically and clinically to plan for patient care. I used the 3-question method for guiding discussions in pre-conference with students throughout the shift and in post-conference to tie everything together. Sometimes the worst thing that could happen actually happened, and a story followed about how the student successfully responded. At post-conference, stories were shared about what actually happened throughout the day, sometimes changing the worst thing into an event the student hadn't considered. If a different worst thing happened other than what the student identified initially, this would lead to a focused examination of the chart for more information. The three-question method is a dynamic tool to use at any time in the course of patient care. Here's an example. A child with cancer came in for therapy and hadn't eaten for several days. Initially, the worst things that could happen were related to pain and the central line. As TPN was initiated, the child started to decline. The student couldn't obtain a blood pressure and there was a decrease in level of consciousness. It turned out that the child was suffering from refeeding syndrome, a very dangerous condition resulting in a transfer to the ICU. So even if the answers to the three questions aren't written down, it encourages a way of thinking. Why the three-question method? Well, it supports understanding of the work of nursing in a tangible way, marrying the didactic with the practice. The three-question method of clinical preparation helps students to understand the work of nursing as they identify and plan how to respond to the worst possible case scenarios. The method emphasizes the essential work of a nurse and responsibility to the patient. Why the three-question method? The method offers a focused way of gathering, analyzing, and applying essential data, saving the student time by directing the student to examine progress notes and reports with intention. Opening a patient chart is like someone panning for gold. Where do you go first for essential information to meet the patient's current needs? Which of the 20 tabs and hundreds of documents do I open first to obtain the information I need to know to care for the patient? Yikes. For example, if the assigned patient has a new diagnosis of diabetes, the student, as they study the disease of diabetes, might choose hyper or hypoglycemia as the worst thing that could happen that has a high probability. This would lead them to further study these two extreme conditions, including signs and symptoms, to recognize as they engage in care. Essential information from the patient record would include studying blood glucose patterns and trends, assessment skills specific to discernment of hyper and hypoglycemia, and insulin administration, whether by injection or drip, and all of the steps that would involve. Because the three-question method highlights the work of a nurse, I prefaced clinicals with two discussions on the first clinical day. One of the first questions I would ask my students is, what is the definition of nursing? The response would often be blank stares and puzzled looks. Why is she asking this question? It's a trick. But no one could articulate in an elevator speech what nursing is. I love this poster because I believe there is some truth. Maybe it would be better to ask your friends and family their definition of what a nurse does. Undoubtedly, your students have this publication and have read it. The American Nurses Association thoroughly spells out the work of a professional nurse in these standards of practice. Here is the table of contents list of the standards. But how does a student articulate in a very brief statement the work of a nurse? The definition of nursing can be found on the ANA website, nursingworld.org. Listed are these key responsibilities: perform physical exams and health histories before making critical decisions, provide health promotion, counseling, and education, administer medications and other personalized interventions, coordinate care in collaboration with a wide array of healthcare professionals. These key responsibilities can be shortened. Nurses are responsible for assessments, health promotion, tasks, and collaboration with other healthcare team members. Here is a chart that compares nursing and medical diagnoses. The work of a care provider is, as we know, different from the work of a nurse. Both professions offer essential members to the healthcare team. The best outcomes are obtained through the collaborative and cooperative work of the entire healthcare team. And as you can see on this chart, The term human response is listed 3 times in the nursing diagnosis column and not at all in the medical diagnosis column. Boiling the definition of what a nurse does down even further for my students, I would sum up the work of a professional nurse as this: nurses treat the human response to a medical condition and promote health. The short statement was easier to remember, and I would emphasize that those 2 elements underpin and drive the work of a professional nurse. When I saw my students struggling to grasp their responsibility as a nurse, I would use an illustration. I would say to the student next to me, "What would happen if I broke your arm?" After the initial gasps and obvious shock, the students would start shouting out, "Well, there would be pain. She would be angry at you. She would be afraid of you. There would be blood loss at the fracture site and swelling." I would point out that everything they said was a human response to the medical diagnosis of a fracture. We would then frame the discussion into nursing diagnosis and actions. There would be no confusion between the fundamental work of a nurse and the fundamental work of a care provider, between a nursing diagnosis and a medical diagnosis. The very first time I used this illustration with a group of students in post-conference, it was because I saw them struggling to grasp the true and important work of a nurse. They were thinking their job as a nurse was complete when they carried out the care provider orders. Knowing the work of a professional nurse well defines the scope of practice, promoting safe practice. The second important first clinical day discussion was about the critical concept failure to rescue. Failure to rescue can result from the accumulation of small clinical clues that are not recognized and addressed. Failure to rescue is at the heart of the 3-question method. Being prepared for the worst thing that could happen is basic to preventing the failure to rescue. There were several times that I saw nurses scrambling at a bedside to obtain and set up equipment during a crisis that should have been expected. For example, an infant admitted for a first-time seizure at home. Wouldn't it be a good idea to expect that to happen in the hospital? In addition to the equipment that was not set up at the bedside, who was going to comfort the mother as she ran screaming from the room down the hall to the nurse's station? We know that we're only human, and we must build systems that the average person can succeed in, and the schools graduate nursing students at entry level, not experts. But if the professional nurse thoroughly knows the work of nursing, being fully attentive to the patient, then failure to rescue will not be a problem. The first and second questions of the 3-question method address this critical concept. Most patients coming to the hospital expect to recover from their illness or procedure. If assessments are incomplete or subtle changes are not recognized, the patient's condition could decline, and as we know, deterioration can be quite rapid. The attentiveness and engagement of a professional nurse is a key component in the best outcome. The 3-question method prepares the student to assess for the most likely event that could be detrimental to the patient, but also how to respond to either prevent the problem or to treat it. Okay, so now we get to the first of the 3 questions. Question number 1. What is the worst thing with the greatest probability that could happen to your patient? The student may think of a spectrum of things, but they are to choose 1 or 2 of the most likely events that could happen while they're caring for the patient. Here's an example. A toddler was admitted for a fever and septic workup. The child has a history of seizures. As the student and I were reviewing the chart, I asked the student, "Well, what's the worst thing with the highest probability of happening that might actually happen?" After a thoughtful pause, the student said, "Seizure." Certainly, this possibility required a thorough study by the student of seizures in toddlers, etiology, and treatment. We proceeded to the next question. The second question I asked was, "What will you do?" This includes monitoring for, preventive actions, and treatment for that worst thing. What will you do as a professional nurse if your patient has a seizure? The student and I talked through what a professional nurse's response would be. Well, the first thing is to remain with the patient. This led to a discussion about delegation. Who could remain with the patient? Who could time the seizure and look at the progression of the seizure? The second thing would be to stop the seizure as quickly as possible, and that is usually by administering an anti-epileptic medication. Well, interestingly enough, there were no orders for an antiepileptic on the chart. From the admission note, the student knew that the patient had an antiepileptic for use at home, so the student called the care provider and obtained an order for an antiepileptic. We reviewed the order as to when and how to administer the medication. The third thing was administering oxygen and the use of suction to clear the airway. This led to setting up the equipment at the bedside and practicing how to use it, in this case, blow-by oxygen and suction. These steps were critical in responding to the worst thing that could happen. The student continued to monitor the patient for any signs of seizure activity. Question number 3. Why is your patient still here? This would be similar to discharge planning. This often includes teaching or instruction. The patient might be waiting for equipment or a consult. But this is an excellent opportunity to teach the student about health promotion. Send the patient home with new knowledge about nutrition or information about community resources. As we know, hospitals try to minimize the length of stay without compromising patient care and to reduce readmissions. Sometimes patients are just hanging out receiving scheduled IV meds, or the discharge is delayed for a myriad of other reasons. Any time with a patient is a time to assess for and give information that can promote health. For example, sharing information with a patient about healthy nutrition may make a greater impact when coming from a perceived expert. Often, I encourage my patient to eat a fruit and vegetable, rainbow colors with meals. I encourage my students to have a website or handouts ready for teaching healthy nutrition. There are many excellent websites that provide handouts or interesting information about nutrition. Reliable websites such as myfooddata.com are fun and engaging. I would compare an apple to apple juice, and that was quite an eye-opener. myplate.gov is an excellent source for teaching healthy nutrition. The point is, don't miss an opportunity to teach your captive audience, your patient, healthy habits. This is also an excellent time to hook them up with community resources. Now, most students don't feel competent or comfortable to tackle complex nutrition or community needs, but they can always use the interdisciplinary team by consulting nutrition or the social worker. I have the student look for the progress notes on the chart written by those disciplines and to contact the person who is familiar with that patient. Students may say that they can't think of a worse thing for their very stable patient. The worst thing could be any number of events on a spectrum of probability. You might have the students list 2 or 3 worst things in order of that probability. What about eclampsia for a person with a central line? Can they monitor for sepsis or teach about central line care? What about a fall? How is a fall risk identified and communicated? What about a sudden PE in a post-procedural patient or a hemorrhage at a cardiac cath site? Have the student think beyond the acute care setting to evaluate what the worst thing that can happen may be at home. Now, here's a time to practice with a partner or by yourself if you're watching this presentation at home. What is the worst thing that could happen is question number 1. Question number 2 is, how will I respond if that thing happens? Question number 3 is, why is my patient still here at the hospital or in clinic? Consider what will get them home as soon as possible. Here are some thoughts. Perhaps there's a newly postoperative thyroidectomy patient, maybe a renal failure patient with hypertension, a newly applied cast for a tibial fracture. Make up your own. Talk about it. I would love to hear what you say about this 3-question method. Let's do a wrap-up. Can you report on the experience you had? How was it to use this method as a discussion without preparation here during this presentation? Did the thought process flow well? Did you use it with your students? And if you did, I'd love to have some feedback. You can email me, and my email is on the last slide. It's pmclay2000@gmail.com.